Hi, sorry, my name's Arun. I'm one of the anaesthetic consultants at Mid and South Essex. We changed our name, so I never quite know where I am. Yeah, so the talk is briefly about some work that one of my colleagues. Is that well? Oh, there we go. One of my colleagues, Manfred Ramirez, who's one of the consultant vascular surgeons at Broomfield with me, and this is the bulk of his work, but he's attending his mother's 87th birthday, so he sent me along. So I apologise for keeping you from lunch. And I'm going to take you back to March 2020. I'm sure a lot of you remember shopping. This is me at Tesco's doing the shop unsuccessfully. And it was a bit of a different time. We were all going into March not knowing what the hell's going on. Are we going to have enough loo roll and are we going to have enough bread? But it was all this unknown. What are we getting into? How many patients are we going to have? How sick are these patients going to be? Are we going to cope? What are we going to do? And that's kind of where this project came from. But at the same time, we had to deal with this. And this is what was a recovery area. So where patients used to go after surgery, wake up, but no more. We kitted it up overnight into an ITU. And we didn't know what we were getting into. And all our peers across the country didn't know what we were getting into. We were listening to colleagues out in Italy, looking at it on social media, seeing that they were really under the cosh, lots of patients, and then comparing ourselves to places like Italy, where they are better resourced than us in terms of level 3, sort of ITU beds, HTU beds, having that capacity that we did not have and do not have. So we built up these, well, fake ITUs, if you will, take these patients on, but we didn't really know where we were, what was happening. And at the same time, at NHS England, Public Health England, we're putting out these national dashboards, which would give us a bit of a flavour of what was going on across the country. And you can see we're getting some regional stats on the left-hand side, telling us where we were or what was happening looking back. But that didn't tell us what the impact was going to come through the front door, how sick these patients were, and what the impact that might have on our staff and our colleagues and what's coming on. So the need, what was the need? It was really to assist managers and the leadership team in our hospital about how do we plan our service and the delivery of care, because we had to bridge what we thought was going to be a tsunami of patients coming through the front door, at the same time as looking after patients that are coming in for elective surgery, for cancer, high-risk surgery, and yet all these patients with COVID. So the ask was to take some of the data sources we had within the hospital, some of the data that was available from, well, at a national level, regional level, and local level, and put it into context for what did it mean for us at our site. And Mid-Essex, or Mid-South Essex back then, we were just one site, and in the middle of COVID, we merged to form Money Saving Expert into three different, three sites into one big trust. But we were really looking at what happened on our side. And a bit more about context is, so Broomfield, where this was based, is a very paper-heavy organisation. Computers are something we look at, but we really look at the notes. And my word, some of them are really heavy. Trust me, I struggle to lift some of them up. But we do use some systems, and they are all in silos. Nothing communicates with each other. And in an NHS organisation which is so paper heavy, back then we didn't have much of an analytics team. And so we were really left with people like Manfred and me and colleagues that have an interest in data. But how do we get all of this into a useful way for clinicians and the leadership team to understand? And sorry, this picture is really to remind me to talk a bit about relationships and forming relationships within what is a diverse community within the hospital, but also putting the puzzle together. And I'll be looping around this theme quite a bit. And I know, like we mentioned earlier, I'm a massive imposter into this system. I'm not meant to be here, but I don't know how I am here. I wasn't going to talk much about data linkage because I'm sure you all know a lot about it. And this is more about a story about the challenges we had and the benefits we reaped as a result of doing this. But in a slide, what did we do? It was mainly batch processing, linking up lots of different data sets. And then we ran that through markdown loops to generate PDFs, which we then emailed out to the entire leadership team, but also all the consultants and juniors. By that, I mean doctors in training, staff grades, associate specialists, and so on, so that we could get feedback, and we'll get into that now. So the first bit of data that we managed to get hold of, because this was a project that started back in March 2020, but rolled on for a couple of years, was microbiology data, which, strangely enough, it was just a chance conversation with one of the microbiology managers saying that actually we have all this data and you can have it. And we started to map out, so on the graph on the left is mapping out PCR tests for COVID, on the x-axis is date, and mapping out frequency about the number of tests, but also the results. And we excluded duplicates to this. But as time went on, we could see where we were in the peak, whether we were improving in terms of the numbers of coming in, or whether we were actually going to face a bit of an onslaught in terms of demands on critical care, because we were having more patients coming in through the front door. On the right is a bit of a bubble plot, looking at not only where in the hospital the tests were happening, but the number of tests that we were doing, and also the numbers of positive and negative results that were coming into there. And then you can also see up in the middle, there big circles, the impacts of us starting to test patients that were coming in for elective surgery. And so the big plot in the middle is something about testing that was happening in ophthalmology. And this was the biggest challenge. I don't know if anyone's used Lorenzo. Yeah, it's hard. We are a Lorenzo organisation. I can't say we use it an awful lot. Do you use it much?
Not anymore.
No, you're lucky. We still use it. I think we've been using it for around 5 years by the sound of it. But it is hard to get data out of Lorenzo. And this is where forming relationships was really key. To the end point, there was a chance Twitter conversation with one of our directors of strategy, who said this is really useful what we're getting from microbiology, but can I have something out of whether these patients are inpatients, outpatients, and what's the end point? Are they leaving hospital alive, or are they leaving hospital in a different way? And we managed, after that bit of Twitter back and forth, getting a data extract, which for me was game-changing, because prior to this point, we didn't even know we could get data out of Lorenzo, certainly as clinicians. And this allowed us really to start looking at how patients left hospital and what those tests meant. So we were able to link Lorenzo data, as in episodes of patients being in hospital, with results that were PCR results that were temporally related. Didn't tell us causation, That was far too much detail for a rendo. But we did manage to work out if patients were leaving hospital, they were tested, if they were positive, and whether they were inpatient, and their discharge modality. So there on the graph on the left, we can see what proportion of our patients, or total number of patients that left hospital dead, which patients, how many patients left hospital alive, and then the total number of patients. Obviously, there's a bit of a lag there in terms of not all of those patients by that date had left hospital, so we couldn't always, there's a bit of a lag in terms of totality there. The graph on the right helps us describe what proportions of patients by age were inpatients in hospital, and how many of those patients died with it on that episode. And you can really see the skew, which helps to focus on our attention in critical care about which patients we need to target and monitor more closely early on, rather than necessarily relying on some national data that came out later on. And this is a plot that we were quite grateful from, Manfred's quite grateful for some help from the Tracker Data Unit, who helped him really supplied some of the code at the back end to pull from the Public Health England's data set, link it down to local authority data, so that we can start to see week on week whether there were hotspots or actually community results were improving or getting worse, so that we can start to see themes in local areas and narrow it down. Obviously, this extract we have shown on an improving trajectory, but earlier on we can see that actually things are getting worse in the community, and in 10 days' time, a week's time, we'll start to see those patients coming through our doors. And then this was really hard work, working out how many of our staff were testing and what their results were. So I'm going to rush through, but essentially this required a lot of scrubbing in terms of wrangling data, because the way our staff tests were handled, they would go through a number of different organisations, changing all the formats and some of the identifiers so that we couldn't necessarily work out who was being tested. So in the end, we wrangled it a lot of, I won't go into too much detail about that, but we managed to work out how many of our staff were being tested and what those results were. So we could start to work out how many staff were being infected at work. But we were also trying to be responsive. And there were themes coming from some of our colleagues going, well, are our patients being infected in hospital and at what length? So this was a bubble plot that we plotted, looking at each ward, and the colour on the bubbles was talking about the number of days between admission to when they tested positive for COVID. So the yellow plot in the middle is showing that nearly 90 days after admission that patient test positive, which indicates that that was a hospital-acquired infection. And then we're also exploring data. So this is the plot that's linking our COVID data with SNAPs. You may have heard of the Stroke Audit Project, which opens up its data and allows us to extract what we submit to them. And we wanted to examine, did COVID have an impact on the number of stroke patients that were being admitted and the outcomes for those patients? And they're highlighted in red in the middle. In essence, we didn't really see a signal there, but it allowed us to explore and respond to colleagues that were asking questions. So benefits, it allowed us to look at stroke mortality, but also understand the impact of things that we were changing. So when we rolled out day surgery, we could see, did that have an impact on the number of cases we were seeing, whether that had an impact on the community, and what they, whether there were more mortality and morbidity associated with that. We could also report on post-pandemic hospital-acquired infections, but it allowed really an improved operational view. So the entire community within the hospital could see what was going on across the site, but also improved the relationship between management and clinicians, so we could start to have an open discussion. And the fact that we all knew what we were doing and what was going on at the site with clarity meant that everyone was a bit happier. You know, that we're all singing off the same hymn sheet rather than lots of sort of rumours circulating around the trust. Feedback loop. This was key, getting feedback from colleagues, knowing what worked, what didn't work, so that we could then go through an iterative process about what we needed to do and what we needed to change. And this is just some feedback that we had from some of our colleagues in response to some of the emails that we sent out. But it really does paint a picture that communication and distribution worked well for us, and it's an organisation that is quite paper heavy. Other sites might go down the dashboarding route, but that wasn't really a way that we had available to us at that time. And community is really key. And this is just some of the number of people that have been involved in the project, because we worked on GitHub, all contributing to each other, so we could really get on and get this rolling. And just some acknowledgement to some of the people within the wider community, including NHSR, that contributed to snippets of code or just information about what we need to do or ideas for us. And really, this is key. So thank you to everyone. Thank you. Any questions? And I won't keep you from lunch too much. Hey.
You talk about the benefits and negatives of doing it as a PDF rather than as a dashboard. Probably the most for about death by dashboard. Everything needs to be on a dashboard kind of somewhere and probably gets forgotten. Do you think emailing it regularly also meant you actually looked at it?
Definitely. But I think some of that is down to organisation. So our organisation is very much paper-based. We don't all use computers because we don't have that many of them and they don't work as well. So accessing the dashboard is quite tricky. Email, with what everyone checks on their phone, so you'll look at it, and that meant that you also can create dialogue. So people get to reply all because everyone gets to get reply, but it meant you have a conversation. Our thoughts are bounded around, rather than a dashboard which you look at in isolation without communicating with anyone else, and then don't necessarily have a way of feeding that back to those people that are producing the dashboard. So in answer to your question, yes, PDFs work well, but it also had a lag. So we were sending this out weekly rather than on a daily basis on spam and junk. And it's getting that balance about how frequently do you need to do that, but also how do you create a dialogue. I don't think either one's the best. Any more for anyone? Oh, hey.
Yeah, so you said this wasn't really arise from the impact. Has it piqued your interest in continuing now the data guys, or have they actually now taken the power of data and seriously established like an analytics group?
So we've got an analytics group, or MSC, but also between us, we've now got sort of MSC, our user group, and we've started teaching our Broomfield, so colleagues, trainees that come through, trying to improve things. And it's also helped that dialogue between analytics and us, which means that now we've got improved access to data, which was a bit more tricky pre-pandemic. And it also means we get to shape discussions around our new EPR that we might get in the future, and what we might want from it, and it being open and being able to output data that we can then analyse rather than what we've got at the moment.